Okay, can you hear us, Dr. Han?
Yes, I can hear you. Good morning,
right.
SJ Park.
I'm very happy to familiar face here. So would you introduce the doctors? Okay.
Well, my name is Horst.
Sievert
Good
there.
morning.
Is
this Horst?
Yeah, that's me. Good morning, Eberhard.
Can't
You
believe
cannot believe it? Why not?
survived.
Thank you for the dinner again yesterday. You cooked excellent.
Great.
Okay, we have another operators. Dr. Kim, Professor Kim is our surgeon. He's always participating in our tower procedure. Thank you, Dr. Kim.
Yeah, it's a great honor to participate in this excellent live demonstration. How are you, Professor Paul?
Right. Our cardiac surgeon actually had performed more than 100 cases of TAVRs. And so I'm very proud of a strong heart team in AMC. Okay, would you start for that?
Okay, this patient is
Do you have a chicken in the
82.
background?
This is 82-year-old female admitted for the exertional dyspnea. Has history of hypertension. Echo showed a severe degenerative aortic stenosis. Next, please. No diabetes, hypertension. Age is 82. STS score is 3.8. Next, please. The echo showed that the ejection fraction is 61%. Peak velocity is very high, 7.3. Pressure gradient is almost 200. Aortic valve is very tight, 0.35. Next, please. This is annular measurement. Annulus short diameter is 16.5. Annulus long diameter is 24. Mean diameter is 20. So annular perimeter is 65. Next, please. The sinuses, sinus valsalva is very big. NCC diameter, LCC, RCC diameter is more than 30. SC junction is big as well. Next, please. LVOT is reasonable, a little bit small. Next, please. Calcification is more than moderate. Our mean calcification volume of our center is 355, but this patient, the calcification is 700, almost 700. Left coronary calcium is not so much, fortunately. Next, please. So this is coronary height. Left coronary height is 13, right coronary height is 17. But the leaflet is, we can see the leaflet up to the left main. So there is some risk of coronary. Next, please. This is one discussion point. And this is posterior aorta. Next, please. So this is Everett R sizing chart. Everett R 26, perimeter oversize is 25% oversize. So next, please. Peripheral is good. Next, please. So this is angle. So do you have any comment or question on patient history and CT measurement?
Any comment on the why? All right, would you show us the size selection, computer
Size
slide?
Everett, yes.
Okay, great. And so you want to choose a 26?
Yes, right.
All right, so perimeter oversize is 25%.
Yeah.
Any other concerns or questions?
Seems very calcified. Do you have a pre-dilatation strategy on this?
That's something we discussed. What do you think? What would you recommend? What would you do?
Well, I have the Evolut expert to my right. No. But I prefer to pre-dil before an Evolut than to post-dil after an Evolut.
The 26 is okay? 20 perimeters oversize?
Yeah.
What would your selection criteria is again?
No, I mean, I agree with it. I think the Evolut Pro here is a good choice, but obviously you can do it with another valve too. But since you choose Evolut Pro, I'm sure it's a good one. Pre-dilatation, yes or no? I know it's your policy at Asan to pre-dilate. Jung-Min, always fights with it. He did me a favor when I was there, standing on Horst's side. But, we are expecting good result, and I think the Pro is a good choice.
So we discussed here pre-dilatation, yes or no. I was actually in favor of not pre-dilating, but they want to pre-dilate.
Yeah.
So if you would pre-dilate, Eberhard, which size of balloon?
Well, I mean, it depends on what you want to do with pre-dilatation. If you want to really create some room or some space, I would take, usually today we pre-dilate with smaller balloons like 20, 22 at the most, and then move forward.
Okay. So I do this a little bit different. When I pre-dilate, then I pre-dilate up to the diameter of the annulus in order
Yeah.
to save one balloon. But
Yeah.
I understand your point.
No, that's a different approach, obviously.
Yeah.
Mhm.
Yeah, for the envelope crossing is not an issue.
No.
For predil,
Yeah.
it's just about
No.
whether you want to expand
So-
the calcium or not.
Horst,
It's more-
when do you predilate or not to predilate?
In really severely calcified valves, much more than this one. So when I'm doing cases in China, they have 3 times more calcium. Then I predilate, and I do this not because I'm afraid I cannot cross. I do this because the valves really tend to dive into the ventricle if you don't do it there. Also in bicuspid. But here, usually I would not. But I think there was another discussion point here about the coronaries. There was a discussion whether we need coronary protection. I agree. So look at do you see the CT scan? Yeah, we see it now. Okay. It's a very short distance between the valve and the left coronary of only 3 or 4 millimeters. But as you see on the CT scan,
Sinuses
there's
are wide.
enough space.
And it does have a sinus there. so-
Sinuses are
Yeah.
wide.
Yeah, okay.
And sinus size is
Any-
more than 30.
Any other concerns or questions?
Right.
If not, then we can proceed.
Yeah.
Just go ahead. So he has already crossed the valve. The safari wire is in the left ventricle.
So we measure the pressure gradient.
Pressure gradient was the highest I have seen for a couple of years now, 200, right?
Yes.
Pressure gradient of 200.
LV pressure, peak pressure is 300.
300 in the left ventricle, or 350, right? We had 350.
Yeah.
So the safari wire is in place, and they have prepared a 16 millimeter balloon. What kind of, is that
G-med balloon.
Z-med balloon? Okay.
What's it?
16,
Relatively small.
yeah.
Horst, can you say that again? What's your size?
The balloon is 16.
All right, so we have our own, criteria. So, to be honest, depending on the calcium
Patient
amount,
ready?
actually our average calcium is 305 something by CT
Patient
findings, and more than
Ventilation?
400 something we did routine pre-dilations, and
Ventilation.
lower than that we did without
Patient
pre-dilation the procedures. In the balloon size wise. To be honest, we don't need a big balloon. The reason why is we're going to do just a modification of the orifice, it's a calcific valve, and we cannot, depending on balloon size and the other atmosphere, etc. Mainly focus on the CT perimeters or CT findings before we evaluate. Meticulous evaluation is how much calcium is, how much diameter, etc., etc. I think it's more mathematical numbers we need, right? So we made a.
Can I see the
So
visualization?
your points are well taken. So the disadvantage of starting with a small balloon is only that if you then have to post-dilate, you need a second balloon.
Yeah.
And I'm coming from a poor developing country, so I'm taking care of that. So now we can, this is, what is the sheath size is
16.
16, so we
Yeah.
have to remove the sheath and insert the valve.
So Horst, I see you inject contrast during the ballooning inflation.
Yeah.
So I only do that if I have doubt in the sizing and we use the appropriate size balloon. And if you just want to open up the calcium, I would save this shot of contrast. So is there any point of contrast in this? I may actually choose a bigger balloon to test the coronary, although it's not very accurate, but this gives me maybe some kind of security that maybe I could protect or not protect.
Well, I agree. So we usually don't do a contrast injection at this time, with the exception of bicuspid valve, and that is when we kind of use the balloon sizing technique, then we use contrast. But in this case, because we know that the balloon is smaller than the annulus, it's the tricuspid valve, so we would not have used contrast here. But on the other side, you know, can clearly see that there's enough room for the, are we waiting for the valve? So there's enough room for the coronary, so we don't need coronary protection.
Okay.
We can use the valve, huh?
여기로 들어갈 수 있잖아.
Sheath has to come out, yeah.
Okay. Can you help
Should I
me?
compress here?
Yeah.
So the sheath goes out.
Okay, I will
I have it.
Okay.
That's fine.
Balloon device.
So the
please.
patient is under sedation
Yeah.
quite heavily. We don't use sedation anymore for TAVRs.
So can you talk? Can you talk?
We
to
can talk to the patient all the time, yeah. I think it's an advantage that you immediately see if something goes wrong, if the patient has pain or any neurological dysfunction, you
밑에
can
좀 보게 해주세요.
detect this immediately.
와이어 잘 잡고.
I'm saying we don't use it anymore. Actually, we never use sedation. So at the later point, we should probably reposition the pigtail catheter.
Yeah.
But for now, it's okay because it may dislodge anyway when you advance the. Let's focus on the wire. We don't need to see the aortic arch. Let's focus on the. And actually, the best projection was AP chordal, right? Let's go to AP chordal then. If you agree. This okay. Now let's wait. Let's reposition the pigtail. The pigtail should really be in the non-coronary sinus. We used to do little puffs of contrast during deployment, and I have reduced the amount of contrast to 3 or 4 cc per puff. Or we need to go more chordal or LAO.
Okay.
We want to see the ring of the valve.
Yeah. Just a moment. I like to reposition the.
Okay. Be careful with the wire. The pigtail. Okay. Yeah.
But because of angle, the repositioning is not easy.
You have to rotate it a little bit.
Test, please.
No. You see where you have to go.
Can you help me?
With the pigtail.
Yeah.
Maybe we need the wire to make the pigtail more stiff.
Wire, please.
I like to have it down there.
So
Doesn't go.
I can handle it.
It's cord. No, it's cord. Let's see this.
Using the wire.
Okay, I need the wire. Yes.
Wire, please.
A regular wire. We can use this one. Yeah. We really want to have the pigtail in the sinus. No, it's not. No. Yeah, that's it. Okay.
Great.
No, keep it there.
Yeah. So we need more quarter.
Yeah, it's good. I think it's good.
Okay.
You are too deep in the ventricle, of course.
Okay.
We can zoom in. Can we zoom in?
Zoom, please.
네. 포크라비로 다시 할게요, 네.
네. 아니 그냥
Which one is zoom in? I don't know.
줌해 주세요 한 개 더.
네.
줌 한 개 더 해주세요.
Here.
Yes, okay. Two 줌.
Okay, that's fine.
Fine.
Yeah.
Okay, could you release? Help
Yeah,
me.
okay. So can we give a little puff of contrast to make sure that we are in the
Test it,
correct
please.
position? Yeah, okay, that's good. Actually, we can start a little bit higher. Yeah, okay. What I do during this phase, we pace with 120 per minute. Don't know whether you want to do this?
No.
No? Okay. Too deep, huh?
Yeah. But it's okay, I think so.
If you keep it there, then
Yeah.
it's fine, but rather deep. I would start a little
Test,
bit higher.
please.
Okay. it's-
Okay.
Yeah. Should not go deeper.
Okay.
Now I do this very slowly.
Test, please. Test.
Little puff. Good.
Good. Oh,
Push.
that's smooth.
It's still in. It's okay.
Now it's good.
Yeah, the pacing is
That's
coming to
contact.
function. So,
Okay.
More.
It's okay, huh? Would you like to do an angiogram?
Test.
I think it's okay. Eberhard, are you satisfied?
I think it's great.
Good. So
You
I
have Dr.
continue?
Ahn on your side, so no worries.
Good.
Just a moment.
Uh-huh.
The release the tension first.
No, no.
Okay.
No, no. Everything's fine.
Okay.
I think there's a bit different situation in the previous cases, right? Non-chronic
Test,
cuspid
please.
is shallow,
Yeah, I know what you mean.
and left chronic
look,
cuspid is too deep, right? The previous one is a contradictory, right? Contradictory, too
Push
shallow
on
in
the
the
valve.
left chronic.
Yes.
Good stuff.
yeah. I totally get it, SJ.
So at this point, we have to pull back the wire, and that is important because
Careful,
you want to
careful
have
now.
you want to have the nose cone away from the frame of
There
the
you
valve,
go.
like this. And now you can gently pull on the delivery system. Now the nose cone is in the
Wire
frame, and now we can re-advance the wire. Okay.
Very nice, yeah.
And now we can go back. Some people like to remove the pigtail before they release the valve. I really prefer to have it there until the end.
Yeah, as you know, so do I.
풀어주세요.
Can you feed in the wire?
Yeah.
Oh, that's okay. That's okay. The sheath.
Okay.
And we need the small sheath again.
Small sheets, please.
Can you compress the groin?
Okay.
I go out?
Yeah. No problem.
Yeah.
Can you check echo, please? We have echo cardiologist, so
Yeah.
안정님 큐브 좀 똑바로 해주세요.
네.
You pacemaker backup lady should be, slow down. You're gonna see that normal
Yes.
rhythm.
Okay. So pacemaker
Fully dependent with
40채로 낮춰주세요. 네.
more slow down.
Can you see the echo
Fully
image?
dependent.
40, 30, 30회.
Maybe complete AV block status. So we need
Yeah.
80 something, right?
80 please. 80회.
Let's remove the wire because that's not good to have the wire in place for such a long time.
Okay, and then you're gonna see later.
Have the pigtail?
So I'd like to show the echo result to the audience.
Don't fluoro when
Yeah.
Victor?
Okay, heart rate was stabilized, 886. Can you see the echo imagery?
Yes, we can see.
Okay, this is a personal experience. The position of valve looks good. I think more than mild degree of power leakage from the IV junction right here.
So it's a little deep, but
More than mild.
what you usually do is your decisions are based on the experience from last week. So if you had a pop out yesterday, then you tend to implant a little bit lower,
Yeah.
and the other way around.
It shows execute the direction of jet 1 o'clock right here.
Now we should can we have a soft glide wire? This is we want to remove the pigtail. You should not just pull the pigtail. I'm not aware of a case where this dislodged the valve, but I think it's safer to remove the pigtail over wire.
I'll move to apical images.
Okay, good. Now let's do an angiogram. Are you relying on echo or are you doing an angiogram?
Both.
Both. Which
And
means you don't rely on the echo.
Can you see the diastolic pressure? Oh.
It's actually good.
Yes.
50, right?
Yeah.
We know, interesting phenomenon, we have a reverse gradient here. So the pressure in the aorta is higher than in the ventricle, which means the flow is flowing back from the aorta into the ventricle.
Ready?
Ready?
Maybe we need post-dilatation, no?
Yeah, Dr. An,
Yeah,
I think
you know,
it's
I
more
was
than
pre-
mild to moderate degree AR
Yeah,
on
I think,
echo.
I think you
PVR.
do. The diastolic pressure is also a little low.
Yeah. So which diameter would you go? Can we see the annulus slide again
Right
from
here.
the CT?
What would you take?
CT?
Can we see the CT again?
We cannot
Yeah.
Can
we cannot see
pretty
any
show us
proper
the annulus
regurgitation.
diameter.
Well, that's not the annulus, right?
So how
Okay.
Okay.
26,
Okay, so-
25% perimeter overdilation, right?
Yeah.
And so what would you do there? There are some mild paravalvular regurgitation and left chronic subside. So what would you do there?
We definitely have to post-dilate. This is not mild, it's moderate. And I would go for a 20 millimeter balloon now.
Can you show the valve in a different projection to see if it's fully open?
Yeah, it's a good idea. Can we see fluoro in different projections?
Ready?
Ready?
And go to Ario as well?
Yeah.
No, we don't need angiogram. Just,
No, not angio.
just on fluoro to see the, here you see, and go to Ario caudal, more caudal. You can see that in this plane, it's not fully open, the valve, right? Okay, so the balloon is prepared, 20 millimeter balloon.
Which size? Do you
We are just discussing, so I would recommend a
What's
20.
what balloon size? What balloon size?
I would recommend a 20. What would you do, Eberhard? You see the CT scan on the screen.
I might be a little bit too aggressive, so.
What does it mean?
No, I mean, if I post-dilate, I want to post-dilate
Yeah.
in order to get rid of the PVL, so I would be
which
probably
size?
a little bit more aggressive than usually you do. I don't know what the
Can you
philosophy.
translate this into millimeters?
I'm sorry?
Can you translate this into millimeters?
So what do you think, a 20 true or
No,
bigger?
no, no.
22
I would
true?
bigger. No, I would take bigger than 22.
What type
So
of balloon?
the valve is 26, right?
Yeah.
Look at the CT measurement.
The short
So
axis
annulus,
is 16.5.
annulus mean diameter was 20.7, and annulus area driven diameter was 19.19.
Yeah, I would take a
Short
20
is-
true.
22?
That's what I would do, but Everhard's arguing for
No,
bigger.
that's okay.
I worry about
think
the
20.
elliptical with
I would go
narrow.
for 20.
Okay.
What is
20, please.
what is Dr. Arndt's opinion?
20, I think 20 is safe. So
See,
this
I knew
patient,
it.
yeah.
The only reason is that he does not trust you.
22,
20. We will do the 20.
20.
Because, yes, the baseline.
What would you
this
take,
pa-
SJ?
Before valve implantation, this patient already
I
have.
think it's a bigger little bit better. I really like a long diameter, annulus long diameter is our limit. Personally, our experience, based on the experience, our limitation for that. And, however, mean diameter is 20, and so I think it's 22 to be okay. But depending on.
In addition, we have to know that the baseline
We can
AR
just go for a 20
Yeah.
and then add 1 cc.
Yeah, okay.
Right?
Yeah, good compromise.
We actually very much depending on the CT findings. Say almost we can make some constant value in oversizing areas, oversizing perimeters, etc. So okay.
I know.
I didn't understand that. Eberhard.
So-
what
so-
What do you try
Horst,
to
what
avoid?
was your, what would you, you would take a 22, right?
I would take a 20.
No, I mean, would you use a 20?
Yes.
Man,
Ready?
what happened to you?
Patient,
Yeah.
patient on
I know, Eberhard, you always think bigger is
Patient
better,
on.
but that's not the case.
implantation,
You had too much wine.
Oh, that's high. Huh?
You got to get lower.
Yeah, that's pretty high.
implantation,
And deflate.
Yeah, go a little lower into the ventricle.
patient off.
I think it was okay. Let's review this. Is this recorded? Did you
Yes.
record it?
Recording 해주세요.
Can we go back? I think
You
it
didn't
was.
do anything with the balloon.
Yeah, this in this plane.
이전 거 보여주세요. 걸로
You would like to see the. Okay.
Okay.
Yeah, it was a little bit higher.
I would do another drill. Just drop it into the ventricle a little more.
Yeah. Do one more. I would do another inflation and go a little bit deeper into the. The
Okay.
middle of the balloon should be at the annulus.
페이싱 준비하시고요.
Deeper, 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 even deeper. A little more. A little more. A little more.
Yeah, you want to hit it with the heart of the balloon, not the wings.
Yeah.
See,
More.
Yeah, so that's okay. Right.
Ready?
If
페이싱
you keep
on.
it there, then it's okay.
페이싱 on. No. Inflation.
Wait,
Wait.
Wait, stop.
Stop.
Deflate,
Stop.
deflate. You should not
Pacing.
inflate the balloon before you have rapid pacing.
guys, what are you doing?
페이싱 on. Not in 페이싱. 페이싱. Back up.
Let's stabilize the patient first. Go to pacing rate of 80 and wait a couple of minutes. Pacing rate 80. No wait.
Okay.
And okay, and do the
Pacing
inflation
on.
only when you have rapid pacing.
페이싱 on.
Okay.
Inflation.
Inflate.
Inflation.
First thing.
Okay, that's
Depilation.
and deflate. And now pacing back
Pacing
up,
off.
go to 80 again.
80.
Okay.
Okay.
And now I keep the sheath. Advance
Yes.
the wire.
PVR was much reduced.
Okay. Could you show us echo?
Yeah, can you see the partial long image? The previous power leg much decreased.
Could you show us the echo on the screen? Can you see the echo on the screen?
Yeah, there is a PVR
Okay.
right here.
Pigtail, please.
It was much reduced from.
That's better. It's not gone.
Right here.
It looks a little better. Do you want to reshoot the angio?
Yes.
Yeah.
Ready?
You never trust the echo.
Ready?
Okay.
I think
That's
it's getting
okay.
better.
That's
Definitely
okay.
better.
Yeah.
Not gone,
Yeah.
but it's better.
I agree.
But this will disappear over time.
Yes, I believe so. So insert pigtail, and I like to remove the whole system.
Which is different from the Edwards. So when you have that type of leak with the Edwards, I think usually it stays, but with the core valve it disappears.
Yeah, there is a two type of leak in echo.
All right. Position the pigtail in there a bit.
Oh.
Okay. Okay, no problem.
And then I like to show you
Contour
the
of
final
the-
arthrogram, and then I like to finish my procedure.
Right.
Ready?
Position.
No, that's good.
Okay,
Yeah,
good.
That's okay.
Excellent.
And RU view. Ready?
Ready? That's very good.
This is a very minimal probable leakage. Yes, I think
That's
post-deal is
excellent.
very good.
And this will, as I said, this will disappear.
Yeah.
Even that-
All right, but we cannot see the probable regurgitation here, right? It's perfect result. All right, thank you for good live case demonstration, Dr. An, Dr. Sievert. Thank you. You're gonna
Thank you very much.
Thank you.
Duk-Woo, can you
Hello,
hear
how
me?
are you? Can you? I can hear you. So,
All right.
and this is the last TAB live case. I'm gonna very happy with Bapat from Columbia University and Dr. Go. I think this is a very nice time to share, Columbia style, the TAB procedure. Before this procedure, the Bini and I saw the, sample valve-in-valve fracture case is very, very enjoyable, So, and the one key message, don't measure pre-pressure.
Yeah.
Bini has some another different opinion about that. Could you briefly comment of that? Why that previous case, you are one of the master of a valve-in-valve procedure. Why require?
So I think in that case, what I observed was that the gradient was very low after deployment, but the shape of the sapien was not perfect. So in these cases, we do, again, so-called fracture to get the best shape. I think it's very important for long term. So in that particular case, although the mean gradient dropped from 9 to 8, but if I can get a more cylindrical shape, I think that particular valve will last more longer. And that's my logic of doing a valve fracture as well.
Yeah. So also this case is, I think there are many debatable portion. And Dr. Go, can you explain patient background?
The case is 79 years old male presented to our hospital with dyspnea, NYHA function 3 to 4. The onset of symptom is just 3 months ago. And his medical history contains ischemic stroke and hypothyroidism. And next. And SDS score is 3.4, so low risk subjects. And next. Echo findings shows the ejection fraction is well preserved, and the peak velocity is 4.6, and mean pressure gradient of 46, and the aortic valve area 0.71. And also, this patient have a severe AR.
Severe AR, based on the
Yes.
line. Yeah. Okay,
And
baseline.
next.
Yeah.
This is the annulus measurement. Annular short diameter is 22.8 and the long diameter is 28.5. Annulus area is 500 and the perimeter is 18.3. And next. Sinus of Valsalva is more than the 1,000, and also the ratio between the sinus and the annulus is 2.29, and the SC junction to annulus area ratio is 1.77. So this patient have a large enough sinus of Valsalva and the SC junction. And next,
Great.
the ratio between the LVOT and the annulus area is 0.84, so a little bit small LVOT. And next. One of the issue for this patient is the total amount of calcium. Total amount of calcium is 700. And next, this is a longitudinal analysis of a distribution of calcification. Calcification is not extended to the LVOT, just focally but significantly located at the leaflet. And next, coronal height is more than 10, high enough. And next, peripheral is quite suitable for transfemoral approach. And next, this is a sizing chart for this patient. And today, we have chosen 26 with 2 cc overfill. That's going to be a 27. So area oversizing is 12% oversizing.
Okay, keep this slide. Okay, so if I'm gonna summary, this is patient 79 years old, female, severe AS. Also has a severe AR on the right. Looking at the angio, we can see the, at baseline there is a severe AR.
Yeah.
Our discussion point is two. First, we do or not predilation. Usually, our Asan Medical Center protocol on the basis of our dedicated CT algorithm, patient having more than 400 calcium, we usually do predilation.
Yes.
Less than 400, we don't do predilation.
Yes.
But this patient has a severe AR. Some, we previously experienced, we do predilation, some case of acute hemodynamic collapse.
Yeah, sure.
Bini is concerned about the underlying AR. If you're gonna do predilation, they make some torrential AR. There is some chance of hemodynamic collapse.
Yes.
Our procedure might be changed to urgent type of procedure.
Yes.
There was one debatable portion. Second one is a sizing matter. Is a 700 calcium, but 26 gonna do 2 implantation. So we're gonna make 12 oversize,
yes.
and if you're gonna select 29, we should choose 4 or 3 cc underpill.
Yes.
That is that patient is borderline zone. It's a 2 point would be discussion point. It's a Bini. Is it your opinion
So,
first?
first of all, we felt that the sizing wise, I think 26 would be better choice. The LVOT diameter is much less.
Yes.
So there's going to be some fixation in the LVOT, and I strongly believe that a fully expanded valve is better than under expanded valve. So I think here it falls in the range of 26 anyway, but we can add 1 or 2 cc extra for our psychological belief. About aortic regurg, it's in Colombia at least we don't do any predilatation unless there is an issue about sizing, risk of coronary obstruction, or it's a bicuspid valve and horizontal aorta. But I think here this is a fixed calcified valve, and that's why there is central regurg. So maybe if we do BAV, it's not going to lead to more AI. But I would like to hear from the panel as well what their practice is.
Hi, Duk-Woo, this is James. I agree.
Yes.
There's no need to predilate this valve with the Sapien. It'll cross just fine. And although there is probably accommodation to that AI, you can make it torrential and make your procedure very unpleasant. And I agree with Dr. Bapat. Prefer to go with the 26, and you can always add more and do a post-dill if you're not happy, if there's some paravalvular.
So any comment from?
on that? All right, Dr. Bang, you raised 2 points. The first one, depending on either way, whether you choose the predilation or not, I think it's not too big matter. However, acute AR and chronic adaptive AR actually is totally different, right? And so for particular this patient, even in the severe AR, adaptive, and actually, immediate after balloon angioplasty, not too much concern about that. Right? Second one, depending on our calcium amount, actually it's based on our average level is a relatively larger number of calcium. That's the reason why I choose a relatively smaller. We've discussed already, and 26, and a little bit over inflation, then maybe better. Third one, actually the position of calcium is totally, they can make a little bit different, clinical outcome in terms of calcium location is a leaflet side, and particularly this patient has a really big sinus ratio. I think it don't too much about concern in terms of dilation in the calcium depletion or something like that. And exactly the same way in I think it's an oblique valve, something like that. And so we got some ideas how big sinus ratios, how the location of a calcium, where it is. We can match the exact size of a select, device itself. That can make I believe better outcomes, right? More data-based, mathematical experience is more better than just to. So we are just starting how make a device selection in terms of self-expanding devices. So we're gonna just start how we can make a kind of a tab scoring before the system, the big calcium location, calcium amount, sinus ratios, many factors actually influence to choose the selection, size of selection device. And that's the matter in terms of reduce the hormone pacemaker rate, reduce the, even in the stroke rate, something like that. Right, that's our principles. Right?
Very nice comment.
And your pacemaker rate is very low, no?
However, you know that if in absolute R situations, I really like a little bit bigger size perimeters to 30, the higher frequency of a permanent pacemaker rate. No doubt about that. And nobody have a data, but tabs important. Second one, calcium amount is very important. Third one, size. If you want to choose, okay, based on the oral big one, 34, absolutely the frequency of a permanent pacemaker is high. So the reason why is we have to consider about the more, database, selections and, perimeters, 20%, 20%. If high, large volume of calcium, we're going to select 20% and maybe dilation of the balloon, something like that. That is more, we have to pursue the beginners in terms of any interventionist. Okay, that's the point.
Very nice,
Very
comment.
good.
Very nice comment.
Thank you.
So, and Professor Kim, can you comment about the echocardiographic finding? Okay, with this patient was MAC, and we already measured the echocardiographic finding.
Can you see the echo image?
할
This
때?
is a parasternal long axis view. The LV function looks good.
그다음에 사파리하고
And you can see a severe opening limitation right here. The heavily calcified aortic valve. The severe AR was noted right here. Unfortunately, the shoulder exit is not so good, like this. This is an apical four-chamber view. Oh, I'm sorry. Yeah, the moderate degree of functional MR was noted right here. The baseline electrocardiogram shows atrial fibrillation. There is a bit-to-bit variability here. The average aortic valve Vmax was 5.0 meter per second.
Okay, got it. So, and can you show us the pressure gradient hemodynamics before? Okay. Can 보고 있어 안에서? 네. Okay.
네, 나옵니다.
Okay. This is our baseline hemodynamics, and then atrial fibrillation. We're gonna start our procedure. So, and the Safari wire first. Okay, here we already passed the wire. 자, 이 뷰 같은 뷰죠?
네, 같은 뷰입니다.
femoral pressure.
It's a valve.
Can you go back to the floral view?
Yeah, this is a floral view. This is Safari. Okay.
And it's extra small or
Yeah,
small?
this is extra small. Okay. Okay, got it. 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, 3. Okay, got it. And then I would like to the direct implantation. Yeah, okay, got it. 이거 연결을 어디?
So I think the other important thing
오케이,
is
잠깐만 이거 잘 봐봐 아직.
we like to do slightly higher implant, but here we are going to use 2 cc extra, so
yeah,
the valve is
2
going
cc.
to completely expand.
Yeah,
so maybe
yeah.
50-50
Okay.
to start with is not a bad idea.
So okay, got it.
Orientation confirmed.
Orientation confirm. And
It's
then
another Columbia style.
yeah. So during the implantation, I'd like ask implantation is the Bini to show what is Columbia style. Okay, we showed the 3 different styles. First one is the Asan style, slightly faster, and the Northwestern style slightly slower.
He'll be just right.
We have to do
Okay, got it.
something like
저기 위에 보여주고.
2-stage.
Okay, got it.
That should be
Okay. 자, 보시면 한번 맞춰보세요.
quite.
Okay, I do.
됐어? 여기야?
Yeah, I'm catching the wire.
오케이. 다 됐죠? 오케이. This is a mapping. Okay.
We always relieve the
Yeah,
tension.
yeah, yeah. That is also our
Yeah.
step.
There we go. So
Okay.
you want me to turn?
Okay, got it.
You want me to flex?
Yes, I'm gonna
Turn
do
you.
the flex.
Okay.
Okay, thank you. Okay, got it. Okay. 자, 우리 페이싱은 체크 다시 안 해도 되겠지? 오케이, 와이어. 자, 뷰 딱 맞춰놓고.
필요하시면 테스트도 하겠습니다.
딱, 오케이, got it. 요 뷰가 그 뷰야?
맞춰보겠습니다.
자, this is, planar view. 오케이. 자, 센터에 놓고 들어가기 전에. 오케이. 딱 맞죠?
네.
자, 이제 들어갈게요. 오케이. It's a slow. Okay, wonderful. And then, okay, slightly pull back. 자, 혈압 잘 보고. One more, slightly more. Okay. I'm gonna slightly positioning. Okay, test.
테스트.
Slightly.
I think that's perfect.
Okay.
Yes. And then slightly pull back.
Coaxial tension is good.
Okay. 자,
You do-
test.
You do 50-50.
I think this is
I
not.
think
yeah.
this is, we could be 1 millimeter higher.
Okay, got it.
Yeah.
Okay, test.
The whole idea is you can see the calcified leaflet. We want to
Okay.
be just on
yes.
top of it.
I think this is good.
살짝
Okay.
혈압이 떨어지고 있습니다.
Test. Okay. Blood pressure style. Okay, got it.
레디.
Okay, everybody ready?
In systole it is,
Okay.
Okay, so we'll go,
자,
I'm just going to inflate
Pacing on.
10%.
Okay, contrast. Okay, inflate.
That's good.
So are you happy?
Okay, okay, happy. Okay, 1, 2, 3, 4, 5. Deflate. Okay, pacing off.
Position is perfect.
Yeah.
Perfect.
That, that is Columbia style. During the inflation, are you happy?
80,
Okay, keep the wire.
Careful.
Okay,
80-20.
okay, so.
I think the reason is we feel that
Okay,
if
여기
you
보면서
want to
하나, 둘,
adjust,
셋.
then you want to make adjustment before
자, 우선
continuous
먼저 한번
deployment.
찍을게요.
네,
자, 줌하고.
줌했고요.
You're gonna check it out, the angel.
잠시만요, 선생님.
텐션.
네, 됐습니다. 레디.
Okay,
You want to
are you
be a
ready?
bit more coaxial?
Okay,
coaxial?
풀샷.
Yeah,
Okay,
perfect.
oh.
Perfect.
Okay, can you check it out, echo? Is echocardiography specialist don't hesitate to check it out echo.
We don't need echo anymore right now.
Yeah, you don't need echo for this. There's no AI.
Actually, Dr. Ba, would you inflate the 2 cc more or just the normal size?
This is 2 cc more.
All right,
Absolutely.
great.
We
So-
need 2 cc
We
more.
inflated full.
2 cc more, person
2cc more.
area is a 1,
Yeah.
15 something.
Yeah. And you can see slight, you can see
That's probably your wire.
indentation.
Yeah,
Perfect.
that's probably wire. 빼고 프레셔 한번 바로 재볼까?
You want a picture like that?
오케이, 지금 돼?
I think it's another an advantage in terms of we can measure the 1 cis over pill, 2 cis over pill. We can make a 15% area oversizing, 20%, sometimes 10%. Heavy calcification is 5%, bicuspid 95%. We can separate the whole thing. Almost perfect result like this.
Amazing.
So even in the personally, I think it's a self-expanding evolved R valve. We need those kind of mathematical principles to select the balloon here. Sometimes 34, sometimes 29. That can make us, I believe, really high frequency of a permanent pacemaker, etc., etc. So we just study by CT and even self-expanding device. We want to measure the many variables, right? Calcium location or amount and something like that, and we can choose a little more delicate, precise selection, size of selection. That is our goal in the future.
Okay, we're going to show us the hemodynamics again. The procedure is too much short. Okay. 자,
Shoulder better.
it's a Columbia style. I recognize it.
No, I think we can play the deployment, and the reason we do it is
Oh, excellent.
excellent.
Hemodynamics error index more than 4.0.
So I can show you now here. This is important because
Here.
here I always ask him because in valve we can adjust the position at that point.
During the implantation.
Because if I don't stop, it may be difficult for you to adjust. So if I just give you stop, you can adjust a bit and then I can inflate.
During the 1/3, at the time you are asking me, are you okay? At the time, if position is not so good, the operator sends slowly the push and slightly back. Okay.
And what you need usually is 1 or 2 millimeter adjustment.
Okay. I recognize Columbia style.
I want to know what Dr. Park, Professor Park feels.
And then we're gonna check a final angio. 요거 잘 보인다. 플라나르에서. 자, 줌하고. This is the frame is good. Okay. Are you ready?
Very nice.
자, 됐어?
Angio ready?
Okay. Angio ready. Okay. 풀샷. Oh, excellent.
Just very minimal.
아래요.
Excellent placement.
Yeah.
All right, areocranial view is better to reduce the AR.
Yeah. Okay, fully inflated.
I like this view.
Okay.
All right, not much AR. Oh,
Okay, great.
disappeared,
Wonderful.
right?
Wow, disappear.
It's very tiny, very tiny.
Yeah, I think, Bini and I have a very nice discussion. We are very nice,
Great.
planning. It's about the pre-dilation or not, and the sizing matter, and then some style. Although, we are slightly some different style, same style, but result was finally very, very excellent.
Very good. Very good.
Really appreciate the Bini.
My pleasure.
So what would you stage then?
Thank you.
AI?
Thank you.
All right.
What would you
Trace
say?
AI, I think.
Vinny?
All right. We before remove the holder wires, we confirm like this as at least mild, more than that. We do more dilations. Actually, the long diameter is 20. For this case, it's 28 something, right?
Yeah,
and so we're gonna choose from the beginning 29. However, we choose the 26. The reason why volume of calcium, location, something like that. And so. We pulled out the whole system. Before that, we found this degree of AR. We do 1 cis more, so 1.5 cis more. The very delicate, accommodation can make improve immediate outcome. I believe that we got some data.
Okay, we ask finally Professor Kim, and is there any echographic finding for?
Can you see the apical long axis view in 5 chamber view? You can see small bubble leak right here. I think it's less than mild.
Just a little trivial.
Right here and right here.
Okay, great, wonderful.
Dae-Hee Kim?
Yes.
All right, so thank you for joining us.
Yeah,
Is any,
yeah.
how much?
Mild, I think.
Just not mild, trivial.
Rest mild.
Well, you started with severe, don't forget.
It's a 0 plus.
So any comment and any opinion from panel?
So what about the mitral regurgitation? Because previously
I
showed
checked the
can you show the mitral one?
Okay.
Yeah, so
Yeah,
this is actually
good point.
a good question
Yeah.
because the mitral is not going to disappear now.
Yeah.
We have found that
Yeah.
functional mitral leakage.
Yeah, that was our next mitral clip.
Mitral regurgitation.
I invite you
Next
and
year's
you can see here,
25th TCTAP.
Yeah, wonderful.
So you're doing the clip now, right?
severe degree mitral regurgitation was not.
Actually, in this case,
Okay.
we fix.
All right, any
Very good.
discussion points from the
Excellent.
panels? Okay, why not?
Okay.
Just a minute.
Okay.
I have a question. I think the AR, CPU AR is not matter in this. I think the matter of AR is not the degree of AR. The degree, the matter, one matter is the degree of velocity of increase the velocity of regurgitation. This patient has already have CBAR, so free dilation make some more regurgitation more. That's not matter in patient. That does not result in cardiac collapse or.
Yeah. Thank you. Nice
Right,
comment.
that's a good point actually. Yeah.
Actually, in this case,
Okay.
we fix not only severe AS but also severe AR. Actually, is there any movement or trial to fix severe AR without significant AS? Is there any
So-
trial or movement?
So there are some devices we are using in Colombia now, which is the new Yana valve for aortic regurg, and the J valve, which is being used, and Janier probably can speak on that. It's being used in Vancouver. We have got very good results. The one problem with the AI patient is slightly higher risk of pacemaker, because again, the devices you use is nitinol based, and for AI you need a bit more oversizing. So invariably this leads to higher pacemaker. And the other problem during the procedure is it's very difficult to get the exact coaxial view because of AI. So I think to be safe, we implant deeper. So maybe with experience, we will get better.
Vinny, do you think that this case would be, suppose you had the Jenna valve and the correct size and everything, do you think this would be a good case for Jenna?
I think this would be, it's a nice tri-leaflet device. The calcification is mainly only the leaflet and bit of annulus, not much STJ calcification. So I think from that point of view, and we have seen that the gradients are quite good with the new Yana valve. So, and although she's 79, say if she was 70 and then coronary is going to be, access is going to be a main issue, maybe it's a better strategy. Yeah.
Okay.
Okay, thank you.
All right,
Yeah,
really
thank you.
nice demonstration.
Thank you.
Thank you for Dr. Bach
Thank
and
you,
Dr.
thank you.
Bapat too. Okay,
Thank
Dr.
you.
Goh
Thank you.
too. All right,
Thank you.
great,
Thank you.
Great.